Okay, we move to the next presentation. I welcome Ms. Yolaan Andrews. She's a Human Rights and Key Populations Program Manager at the Networking HIV and AIDS Community of Southern Africa, and she will talk about decentralizing hepatitis and opioid substitution therapy services in South Africa through mobile clinic services. Please, Yolaan.
Thank you so much. I'm just making sure something moves. I'm pressing the green button. Yeah. Apologies, it's not moving. Okay, I'll give you a second. I realize how short I am. Let me move the mic down. Please don't take away from my time. Good day, everyone. I just want to acknowledge a lot of people, but particularly the people who use drugs that are our program users. They share their stories with us and their experiences, as well as their access to services. And we can't do this program without the input in how we can improve. I also like to acknowledge my team, Mimri Mahaso, Andrico Stefanos, and Calvania Pariachi from Nakosa in implementing the People Who Use Drugs program. I also want to acknowledge Tanswala Home-Based Care and Indibano Victim Empowerment Project, who ran this pilot of decentralization using mobile clinics. And then we would not be able to do what we do in terms of hepatitis C treatment if it wasn't for Dr. Mark Sonda from Grooteskiel Liver Clinic, who made access to DAAs possible for NGOs. No conflict of interest from my side. You've been to enough presentations about South Africa to understand our context in terms of people who use drugs. But once again, just to give an indication that we have approximately 82,500 people who inject drugs. This is old stats. This is 2021 stats. There has been no proper mapping done in our country of urban, peri-urban, and rural areas. And I'm sure you will find that we have a much wider population of people who actually inject drugs that need services. We know that about 37% access needle and syringe programs thanks to Global Fund, to PEPFAR, and to other organizations like Sediba Hope, as well as COSAP. We also know that about 7% only are accessing opiate substitution therapy, considering the much needed. What we also want to just make in consideration is that we expanded our People Who Use Drugs program under the Global Fund. We were initially only in 5 districts, and we were able to extend it to an additional 3 districts that are able to then also provide methadone and hepatitis testing and treatment services. What we did realize is we had a problem in terms of retention as well as DAA completion, and it was because we were expecting people to come to our fixed sites, where it was incredibly difficult due to expensive transport costs, but also in terms of the far distances from where they lived or worked or hung out compared to where the fixed sites were. So in November 2023, with Tanswalo in Ekurhuleni and Indibano in Sedibeng, we piloted a decentralized model of providing opiate substitution therapy and hepatitis screening, testing and treatment services through mobile clinics, going to hotspots and going to where people needed it the most. I just want to show you on the left-hand side some data that we're relatively proud of with the little bit limited funding we have. Please note, we have no domestic funding for our program. It's all thanks to the Global Fund. So you can understand why I'm really proud of the fact that we have, initiated 4,119 people who inject drugs on methadone since 2022. We have also, screened over 3,600 people for hepatitis C. We have, found a antibody positivity of 74%. When we did our RNA testing or PCR confirmatories, we actually found it was 82% HCV positivity. And, we had 1,061 people starting treatment thanks to SANAC THU as well as to the Grooteskiel Liver Clinic. So I just wanted to show you some of the data or the results that came out from the decentralization. I hope you can see it clearly. But when we decentralized using mobile clinics to initiate on methadone as well as to screen or test and treat people for hepatitis C, we actually saw some really amazing results in Sediben and Ekurhuleni. So from November 2023, we had a 67% OST retention, and that went up to 91% in November 2024. We also saw with our treatment and completion specifically, we had 365 hepatitis screenings that were only done by November 2023. Once we started using mobile clinics, those screenings went up to 1,059 just in those two districts. We had 122 DAA initiations in November 2023. That went up to 324 DAA initiations. We had 107 treatment completions in 2023, 199 in 2024, but please also consider the fact that it is a 3-month treatment, and there also is, a shortage of affordable DAAs in this country. You spend approximately 30,000 rand on a 3-month course treatment for one patient, which many of us cannot afford as NGOs. We had a 59% cure rate in November 2023. That went up to 86% cure rate in November 2024. And then if I look at our comprehensive services, if I just look at HIV viral load suppression, which we're still working on, we had a 33% viral load suppression in November 2023. It went up to 42% in November 2024 because we were able to provide our treatment at a decentralized level. So I just want to talk about the modalities because Ekurhuleni specifically, due to distances, their services for methadone was just mobile clinics. Whereas Sediben, they had a dual model of having a fixed site at a primary healthcare facility in Sediben, but also providing methadone and hepatitis through their mobile clinics. So in Ekurhuleni, they had 445 OST clients initiated between that 1-year period, and that would lead to a 90% retention on methadone. They had an 89% hepatitis C cure rate for those that were initiated on DAAs via the mobile clinics, and they had a 44% viral load suppression for HIV. But please know, in Ekurhuleni district, they were unable to do universal treat and test or test and treat due to district considerations with the Department of Health. In Sediben, with a dual model of mobile clinic services and fixed sites, that 172 people initiated on OST or methadone via mobile clinics, 248 at their fixed primary health care facility, their public local clinic, and this was at 86% retention. In terms of hepatitis C cure rate, they had a 73% hepatitis C cure rate, and because they are able to provide ART medication as well, they had a 67% HIV viral load suppression using their mobile clinic and their fixed sites. So the data overall through these modalities clearly show that mobile clinic services does increase uptake of services, but also it increases the adherence and retention of these clients on these services. So just a reflection, because you need to know what was the good and the bad, right? I can just tell you the good, but then I would be painting a wrong picture, because we need to understand what the challenges were so that we can look at what are the strategies that we need to have in place from a domestic and from an international perspective to improve and result in more successes. So I think the success was very clear because we were going to where the hotspots were, where people who inject drugs are living, many of them being homeless. It did save time for them, which meant that the people who inject drugs could then go and do economic generation activities, etc. The challenge, though, is that we only had 1 or 2 mobile clinics per district or per site. And because there are other activities that needed to be done, there was only a certain dedicated time that they could have, which was usually the morning, that they could make the mobile clinic services available for this decentralized model of providing methadone and DAAs. So obviously that means we need more mobile clinics to do more work on the ground. Outreach initiatives as a success, we reached our target, which was great, specifically our OST retention target. But the reality is that it was only available in the week. And in a lot of our cases, we insist on treatment support buddies, which are usually sometimes family members for those that are on methadone, especially in the stability phase. And these people were not necessarily able to come in the week for these services. So we need to reflect that we need after-hour services as well through mobile clinics. But this has a danger zone because of the areas that we work in. There was improved OST retention, viral load suppression, and hepatitis cure rates were improved, but we do acknowledge that there were missed appointments, and this is usually related to, lifestyle changes of these individuals that, jeopardize their availability. Demand creation was amazing. It resulted in more visibility, more accessibility, but then also non-PWID clients sort of come into the mobile vans to access comprehensive services, which meant a very careful negotiation with them about why, we could not necessarily support them on certain cases. We were able to also provide comprehensive services, so they presented themselves for acute illnesses, and we were able to assist with that. But we also have to acknowledge that human rights violations still occur where their personal belongings are confiscated, their medication is stolen, there are forced removals by the municipalities, which means we have to spend more resources buying more medication for those that has been confiscated, but also for, for tracking them as well. The success was family reunification, but we also acknowledge that because of polysubstance use, they're not just on opiates, they are also on other drugs, benzos, other stimulants. The reality is that there was some drug withdrawals during the waiting period, which means that they left during that time when they needed to be seen. I just also want to acknowledge that some of the concluding remarks is that, for sure, we want to see sustainability in this country. This funding crisis that we are in is a serious wake-up call that we cannot rely just on international funding. We need to have Department of Health, Department of Social Development, we need to have the Department of Basic Education, all of them multi-sectorial with municipalities coming forward to looking at, integration within local clinics and not just tertiary hospitals, because we need to make these services as accessible as around the corner for people who use drugs. But saying that, the reality is, and the Ministry of Health and the Department of Health can agree, the reality is they know mobile clinic services works. People want these services at their doorsteps, and it improves adherence as well as treatment as well as cure rates. So we need to continue that, but we can't just rely on international funding. Domestic resourcing is key for the expansion of harm reduction services, opiate substitution services, as well as hepatitis services. And then I just want to say that the last thing is, as part of a stigma and discrimination reduction, having visible mobile clinics supports that, because it's shown a concerted effort to the community that we're not just pushing drugs, we're pushing harm reduction, we're pushing family reunification, we're pushing for the community support of harm reduction and these type of programs. So have more mobile clinics means you are actually reducing human rights violations. Thank you.